I was an A-level student when I heard about John Snow, so perhaps there are some in the audience who also know about him. He was a medic in the 1800s, and he was from a working class background, which might be why in 1849, when he suggested that cholera came into people's bodies via the mouth, for example via water, rather than coming in through the air, no one really listened to him until the cholera outbreak of 1854. So cholera is an infectious disease and it can be fatal. And hundreds of people died in London. So what John Snow did is he went door to door across the area with the highest prevalence, the highest frequency of these cholera cases. He knocked on every door and he asked in that household, did you have a cholera case? And he established how many cholera cases there'd been in each household. And he also established where there hadn't been cholera cases. And he put them down on this map behind him, which is a replication of the original. And by looking at the frequency of the cholera cases, where there'd been lots of episodes of infection, he was able to determine that there was this water pump that was likely to be the source of the infection. But even more important than where there had been cases, the thing that clinched it was where there hadn't been cases. So there was a brewery next to the pump where they tended to not drink so much water because they were drinking beer, and they had fewer cases of infection, maybe more cases of other life-threatening diseases, but fewer cases of infection. And then there was also a workhouse. So workhouses in those days, you know, bastions of just sites of infection. People did not have the best health outcomes, but there were far, far, far fewer cases in that workhouse than would have been expected. And that's because they had their own well. So it was finding out these absence of cases of variation who had and who had not that clinched what the source of the infection was. And by removing that water pump, they saved lives. And that's what epidemiology is, looking at the distribution of health, the distribution of disease within a population. Who gets what and why? What's the variability? What's a variance within your population? And using that to draw out things that tell you more about the disease. So epidemiology can tell you about the burden of disease, that is, how many people are healthy, how many people have disease. It tells you about natural history. What does health look like? What does disease look like? What does it do to the affected person over their life course? It can start to bring you closer to etiology, that is, what might be the causes of the disease. And also it can tell you something about outcome. What's the difference between people who have good outcomes once they get disease and bad outcomes? So I'm going to talk about epidemiology in action, that is the research that we do. And I sit within, as you heard, the Vision and Eyes group. And here's our last Christmas photo. The person that you can't see because she's taking this photo is our group leader, Jugnu Rahi. The thing that pulls us all together is passion about improving outcomes for children who are at risk of blinding disorders. Because vision is a miracle, right? Vision is a miracle. Just think about all the things you've done this morning since waking up, and think about how much harder they'd be if you had impaired vision. Vision is the sense we most fear losing. And also, apart from the impact that visual impairment and blindness has on the individual child, has on their family, it also impacts on wider society, because those children need and deserve the extra support that allows them to be the best that they can be, which is expensive for a nation. In the UK, the most common cause of childhood blindness is a rare disease. That child has poor vision because they have a rare disease. And a rare disease is one which impacts on fewer than 1 in 2,000 individuals. And the reason why we know that is because of work done here at ICH. So a surveillance study, sort of like John Snow did, looking around the country to see which children have poor vision and looking to see the characteristics amongst that affected population. That's something that was done here in 2000 and has recently been updated in another study, BCVIS 2, which was just recently completed. Okay, so let's drill into rare disease. I've told you that individually, rare diseases are uncommon. However, there are thousands of rare disease. There are at least 6,000, there may be as many as 9,000. So if you take them collectively together, 1 in 17 people in the UK have a rare disease. And that's 3.5 million people minimum. So rare disease is common. Rare diseases also typically affect childhood. And 1 in 3 of those children with a rare disease, for them, that rare disease is impacting in some way on their eyes. Childhood cataract is a rare disease. So you've got a lens inside your eye. It's like a transparent Smartie or transparent M&M, casing on the outside, clear, transparent fibres on the inside. Cataract means that those fibres are going cloudy. It's an age-related process, so like your hair goes grey, at some stage in your later life you're going to develop a cataract. But some children are born with this clouding of the lens. And even though it's rare in the UK, globally, it's the most important cause of preventable childhood blindness. And as such, many countries globally care about it, and that's why in the UK, every child that's born are going to have their eyes checked in the first few days of life, every child, to make sure that they don't have a cataract, so that we can do something about it. And what we do is surgery. So we make a hole in that casing and suck out the chocolate, suck out the clear fibres. Because that's not necessarily enough to return good vision. Without that lens inside the eye, things are really blurry. So you've got to replace that focusing power. And we can replace it with contact lenses and glasses, which can be a challenge for families to manage. So about 20 years ago, surgeons started putting artificial intraocular lenses inside the casing in the hope that that would help children to see better. And it just shut off. People started adopting it across the world. So in 1997, about 4% of surgeons would consider putting one of those lenses into a baby's eye, into an infant's eye. By 2001, that was 1 in 5. And by 2008, that was 82%. And again, the reason why we have that UK figure from 2008 is because of a study done here by our group. So recently, we looked at outcomes for childhood cataract for children who'd had surgery with or without those intraocular lenses to see if indeed they were resulting in better outcomes. We had to make sure we got all those spectacles, all those cases of Christmasitis, all those cases of cataract. And to do so, we have this thing called the British Isles Congenital Cataract Interest Group, which is all the clinicians, all the surgeons across the UK and some in Ireland who manage children with this disease. Because as you saw earlier, if we just get a few of the cases, we can't necessarily pull out the patterns of interest. It was a prospective, that is, following these children on through time, inception cohort study, so following a population of affected children at the point where something interesting is happening to them, that is, they're having the cataract surgery. And we identified all the children in the country, and we know we have them all looking at databases that the NHS has, who underwent cataract surgery between January 2009 and December 2010 with or without these artificial lenses. We recruited them before they had surgery, and we watched them over time to see what happened. It was active surveillance, similar to what John Snow did. Remember, he was interested not just in the cases, but also where there hadn't been cases, because that's the way you ascertain whether or not you have a true picture of what's going on in the population. So we had regular contact with this group to confirm whether they'd seen a case and to confirm that they hadn't seen a case, and that's the reason why they hadn't contacted us that month. We had harmonised definitions. We were precise about what we called everything, and we made sure everyone used the same definitions. And we had a standardised data set. Everyone collected the same information in the same way. And through this study, by following up these children, we identified that these artificial lenses were actually not associated with better outcomes. In fact, they were associated with a higher rate of complications. And by this time, the majority of young children in the UK were actually having this intervention, so we reversed clinical practice to make things safer for the children having surgery. And if you want to know more about it, there's a podcast available online. If you search for Lancet podcast lens, it'll come up as the top hit. And if you search for PPP, that's Population Policy and Practice, and GOS, Great Ormond Street, and ICH, Institute of Child Health, you'll find out more about our department and the impactful work we do, work that affects the population, affects health policy, and affects clinical practice, what's actually done by the clinicians. So you'll find out about the work that was done that looked to see what the impact of visual impairment and blindness had on your later life socioeconomic outcomes. work on how we measure visual disability, not just by measuring what children can see on a chart, but by using their own life experiences to measure how their visual problem affects their life. You can hear about the work that we've done that underpins the programme that's currently in place, whereby every child in their first year at school will have their vision tested to look for visual problems that might need interventions. And there's other work outside the eyes that's impacting the child globally, although vision does impact you globally. But for example, people in our department are looking at innovative data science to reach conclusions about what needs to happen for the population of children, not just in the UK, but globally. There's a group within the department who's looking at children, pregnant women who have infections following their children after they're born, to see how those infections during pregnancy have affected their later life outcomes. If you look in your little red books that you'd have had when you were children, or that your younger siblings may have, there's a growth chart that will be present in your GP's clinic. The work that was done to underpin the information we need for those kind of growth charts was done here. In fact, that red book, the work that underpins the sections in that red book, was again done by a team based here. Because if you find out who, and then you find out why, you can change the world. Thank you very much.